If you see me, you know it's about lupus. You know that we have a lot of lupus in Atlanta and consequently a lot of lupus nephritis, so it's a pleasure to have Dr. Brad Rovin here. We were talking this morning about this funny word, thought leader, and I suppose a lot of people do consider him a thought leader. All I know is that he is very thoughtful. He's very thoughtful in the care of his patients, thoughtful in investigation, and thoughtful in training his mentees. Dr. Rovin is the director of the Division of Nephrology and vice chairman of medicine for research at the Ohio State University, Wexner Medical Center, where he is the Lee A. Hebert Distinguished Professor of Nephrology. He studied chemical engineering at Northwestern, went off to University of Illinois Chicago for his medicine degree, and then finished his residency and nephrology fellowship at WashU in St. Louis. He not only studies lupus nephritis, but he's interested in the pathogenesis of glomerular diseases in general. He focuses on biomarker development and experimental therapeutics. He's also established this amazing multidisciplinary lupus, vasculitis, and glomerulonephritis clinic from where he's done some tremendous investigation, as well as starting an advanced fellowship for autoimmune diseases for nephrologists and rheumatologists. Brad, welcome.
All right. Well, great to be here. I was telling, as Sam remembers, I was supposed to come last year, but I had a little bit of a bike accident, so wasn't able to come. So I'm glad that I could come this year, and I'm going to talk to you about sort of the way I think about managing patients with lupus nephritis, and we'll go from there. Okay, so I want to start with a case, and we're going to sort of use this case to get some things across over time. This is a 20-year-old Hispanic female. She was diagnosed with lupus about 4 months ago. Clinically, she had some facial rash, some pleurisy, a positive ANA, and a positive double-stranded DNA. At the time, her urinalysis was unremarkable. Serum creatinine was 0.7, so as expected for a young woman. And she was started on a modest dose of prednisone. She had very good symptomatic resolution, but she really didn't tolerate the steroids very well. And she self-tapered the prednisone, and that's not an unusual story. So she was seen in follow-up and found to have new pedal edema. And at that time, her urinalysis showed blood and protein on the dipstick, and there were several acanthocytes, and I'll show you what those are in a minute for those of you who don't get to look at urine very much, and one white cell cast on microscopic examination. Her serum creatinine was 1, and so just keep that in mind. Even though her serum creatinine was sort of in the normal range, it isn't normal because we had a healthy baseline and her serum creatinine was 0.7, and I think we miss this sort of small degrees of renal insufficiency in our patients quite a bit. Complement C3 and C4 levels were low, and she also had hypoalbuminemia, and her protein to creatinine ratio was 5. So a kidney biopsy was done. Okay, so first I want to go over a few little things about the diagnosis of lupus nephritis. This is the very simple algorithm that we use when we see patients with lupus in our clinic. And generally speaking, sometimes we get referrals in for lupus nephritis, but generally speaking, the patient will have lupus and then develop something that suggests lupus nephritis. I think the testing for lupus nephritis is indicated at the very first presentation of lupus, and that should be done probably in the rheumatology clinic because that's where they mostly will get referred, and then yearly thereafter. Also, retest anytime there's a suspicion of a flare. The screening panel is very simple, just serum creatinine and a urinalysis, a dipstick, and a sediment. And I realize, and I was happy to hear at breakfast this morning, that you all do look at urine here in nephrology. A lot of places don't get to do microscopy anymore because you have to be CLIA certified, et cetera. So look for evidence of abnormal proteinuria or urine sediment. And don't forget, just using the dipstick is a very inaccurate way of looking at proteinuria. So a dipstick protein of 2+ at any specific gravity should catch your attention. However, if you have 1+ protein but the urine is dilute, that should also catch your attention. So you do have to look at the specific gravity. And just for everyone to know, the new SLIC criteria for lupus nephritis have actually removed the urine dipstick from the diagnostic armamentarium for lupus, but we still do them. And then look at the sediment for red cells, white cell casts, but you have to be in the absence of infection. You can also look for evidence of reduced GFR, glomerular filtration rate, and that can be a serum creatinine above the normal level in your laboratory, but most of the time you won't see that, and what you'll see is something within the normal level, but it may not go along with the body habitus and muscle mass of the patient you're looking at. So be mindful that young women who present with lupus often have a small muscle mass, and their normal healthy serum creatinines may be in the 0.5 to 0.6 range. So if they're consistently 0.8 to 0.9, they probably have some renal insufficiency. The other thing is the abnormal GFR or serum creatinine should be attributable to lupus and not to other causes. And just to remind everyone, you can have impaired renal function in lupus because of the disease and because of the medications that they often are on in the background, like steroids. Infection, hypotension are certainly important to think about, volume depletion, nephrotoxics agents, both contrast media and nephrotoxic drugs that these patients are often on, and then hemolysis, thrombosis, and cardiac failure can also have their toll on the kidney in lupus nephritis. So, just to get us all on the same page, these are the prevalence of the clinical manifestations of lupus nephritis. So everybody with lupus nephritis has 100% proteinuria. And that's sort of not true, because we define lupus nephritis by proteinuria. But it turns out that there is something called silent lupus nephritis, and I just throw this up here. In a series of 200 lupus patients, none of them had overt lupus nephritis clinically, so they didn't have proteinuria, they didn't have much in the way of hematuria. Only 17% of them had a normal histology. Now, granted, most of those folks had very innocuous lupus histology, and we'll go over those in a minute, but some of them actually had the more proliferative types of glomerulonephritis we see in lupus, and some of them had membranous nephritis seen in lupus. So, the fact that everybody with lupus has proteinuria is an artifact of the way we define lupus nephritis, but that doesn't mean the converse isn't true. And I think that the autopsy studies have shown that almost every single person with lupus has some involvement of their kidney. It just may not have ever come to clinical attention. Nephrotic syndrome or nephrotic range proteinuria in about half the patients, microhematuria in most of the patients. And the other thing that I've highlighted here is what we've been discussing is that impaired kidney function, the low end of this may be because we failed to pick it up because we don't know what their pre-disease serum creatinine was. But I think truly if you were able to know that, most of these patients have some renal insufficiency at their first presentation, at least of proliferative lupus nephritis. So this is sort of show and tell. I think the urinalysis is rapidly becoming a lost art. We just went through a huge argument at our institution when I bought new microscopes that we weren't allowed to do urinalysis because we're not CLIA certified, and the high school student in the laboratory has more experience than the nephrologist, but don't get me started. So, what do we look for in the urine when we're looking for glomerular disease and certainly in lupus nephritis? Well, we look for red blood cells, but we look for evidence of glomerular bleeding. So we look for, as you may have heard when you've done your nephrology rotations, dysmorphic red blood cells. And there's a whole bunch of dysmorphic red blood cells, but the ones in particular that are indicative of glomerular bleeding are called acanthocytes. And this is an acanthocyte. So you see the normal red cell body here and this big bleb. You can see it here, and now if you put another bleb here and a smile on the face, it looks like Mickey Mouse. So they're Mickey Mouse cells, and that's how we teach our fellows, which doesn't sound like it's much, but certainly people remember it. Red blood cell casts, as you all know from medical school, are indicative of glomerular bleeding. White blood cell casts are easily distinguished from red blood cell casts. These are granular cells with nuclei. Now, the little caveat about white blood cells and white blood cell casts in lupus is these are young women. They could have urinary tract infections. They could have pyelonephritis. So again, be careful that the white cells and white blood cell casts are in the absence of infection. Now, These are what you all have learned in medical school as muddy brown casts, ATN casts, acute tubular necrosis. These are not part of lupus, generally speaking, and if they are present, you should consider things that cause ATN or acute tubular necrosis, including infections, bacteremia, sepsis, and sort of the things we discussed already, nephrotoxic drugs, hypotension, heart failure. This is one of my favorite pictures. This is how you can always remember how to make an acanthocyte. This is an electron micrograph of a patient with lupus nephritis. And here you see inside the glomerular capillary loop are some very nicely uniform shaped red blood cells, and these will have normal morphology. And you can see this one here and these squeezed through the basement membrane, and they went into the urinary space. They went into Bowman's capsule. So when these things go down the tubule and get urinated out, then you have the acanthocyte. As you can see here, they're all misshapen. And the way I think about it is they get damaged as they go through the glomerular basement membrane. This is an in situ red blood cell cast, so this is also a patient with lupus. They had a kidney biopsy, and you can see inside a tubule, a red blood cell cast is forming, and this is what it looks like in the urine. So I just thought these were really cool pictures, and I wanted to share them with you. Normally, we just do the urinalysis. So what about renal function in lupus? We're pretty old-fashioned at Ohio State. We measure serial creatinine as a way to monitor renal function. You all get eGFR, as do we, on your laboratories, and let me just go over a little bit about what we think about that. But first of all, serum creatinine can be increased or decreased for several reasons that are independent of the glomerular filtration rate. And you have to keep these in mind because your patients with lupus or other glomerular diseases may be on these medications. For example, tubular secretion of creatinine is actually decreased by several drugs. The one that we think about a lot is trimethoprim, because often these people may be on steroids and they're getting pneumocystis prophylaxis, and I know it isn't called pneumocystis anymore, but that's too bad. It's the same organism, I think, just the ID folks renamed it. And they may be on Bactrim, so this can increase your serum creatinine. In patients who are having low serum albumins, which a nephrotic patient would potentially have, tubular secretion of creatinine is increased and your serum creatinine will be artificially lower. I highlighted this one because I think this is something that we tend to miss. High-dose corticosteroids acutely can affect skeletal muscle metabolism. As you know, creatinine is derived as a byproduct of skeletal muscle metabolism. And so in patients getting megadoses of steroids, which they often do at the beginning of their treatment, although we would like to change that down the road, they can have an increased serum creatinine. This generally gets better as the steroids come down to a more reasonable dose and the patient starts getting treated and responding. So this has actually cost me enrollment of patients in clinical trials because you can't explain to the trial physician that the serum creatinine is above the limit simply because of the steroid and next week it'll be better. But again, please be aware of this and don't panic. I think the worst thing to do is to panic and assume that the patient is getting worse and then stop what you're doing and do something else. A diet high in cooked meats, the serum creatinine is increased. A vegetarian diet, serum creatinine is decreased. So getting a dietary history is relevant in these patients. So what about eGFR from the estimating equations? It's routinely reported. I'm sure you have it in your laboratories. First of all, none of these have been validated in a typical lupus population. These are all people with chronic kidney disease, older, and generally not young women. All of these equations are based on the serum creatinine. That's the most important variable in these equations. And so all of these things we talk about in terms of uncertainty of measurement of serum creatinine and what it means still apply to the estimating equations, okay? And the bigger problem is that all of these equations assume that patients of the same age, race, and sex and serum creatinine have the same rate of serum creatinine production. And of course, patients who are wasted or patients who are very athletic bodybuilder types, they don't. And so we we're forced to use the EGFR because that's what's done in a lot of clinical trials now, and that's what's reported, but you get just as much information, we think, from the serum creatinine. Okay, what about assessing proteinuria? I told you already that even though the dipstick was a criteria for the ACR in the old days for lupus nephritis, it's not part of the new SLIC criteria for lupus nephritis. This has gained a lot of popularity in the nephrology community. The random spot protein to creatinine ratio, which means when they come into clinic, you ask them to pee in a cup and you do a protein and creatinine and divide the protein by creatinine, and that gives you an estimate of the 24-hour proteinuria. So if anybody knows the literature from Ohio State, my former chief is very much against this, and so we've published a lot of papers talking about the reliability of the spot protein to creatinine ratio. I'll show you one of these articles here. So this is the spot protein to creatinine ratio over the 24-hour protein to creatinine ratio, and then the x-axis is the 24-hour PC ratio. So if the spot was actually reflecting what was going on in the 24-hour urine, all of these would line up on this line. And as you can see, there's a huge amount of variability here. Now, this is about the third or fourth paper that our group has published on this. Very recently, for those of you in nephrology who know the Neptune trial, they looked at their non-lupus patients. So these were patients with other types of GN. Neptune studies membranous nephropathy, focal segmental glomerulosclerosis, and minimal change disease. They have also reached the conclusion that the spot protein to creatinine ratio is not accurate in those proteinuric kidney diseases. So I think we're left with a 24-hour urine collection and a 24-hour protein to creatinine ratio. Now, several years ago, we published a paper looking at the first morning void protein to creatinine ratio. It turns out in lupus patients that correlates very well with the 24-hour urine protein. Be mindful that is not a spot ratio. That's timed, and the timing is over the course of the evening. A recent trial was completed in lupus using a calcineurin inhibitor. They measured 24-hour protein to creatinine ratio and the first morning void as a way of just helping patients out by not having to do a 24-hour urine. They tell me, and they're going to show me the data because we're going to analyze it and write it up, but basically this confirms that the first morning void may actually be a good measurement. So keep that in mind. This is inaccurate. Now, I'm not saying not to use it. I use it in my clinic all the time. I'll get a spot ratio. If something looks like it's changing, then I'll confirm that with a 24-hour ratio. Okay, this is audience participation. True or false? A kidney biopsy is needed in the diagnosis and management of lupus nephritis. Who agrees with that? Anybody? Raise your hand. Kidney biopsy. Okay, so half of you don't care or half of you say no. All right, I'm gonna try and convince you that it's necessary. And later in the talk, I'm going to try and convince you that more than one is necessary. We should biopsy people a lot. And there's a pathologist in the audience. He agrees because it keeps him in business. But there's more than, there's science to it. So this is a 50-year-old Caucasian woman. She had alopecia, positive ANA, double-stranded DNA, low complement levels. So she has ACR criteria for lupus. She had antiphospholipid antibodies, a lupus anticoagulant. She was hospitalized. She had AKI. It was not due to lupus. She never had lupus nephritis that anyone knew about, right? So she had sepsis and dehydration post-op. Her serum creatinine peaked in the 5 range. Then it came down to 1.2. She had a pericardial effusion. A drain was placed. And then at some point down the road, she was found to have hematuria and proteinuria of about 1.2 grams in a 24-hour urine collection. So does this patient have lupus nephritis? Yes? Anybody? Okay, some people. All right. So we did a kidney biopsy, and this is actually what we saw. She had interstitial fibrosis. She had thickening of the arteries, and she had intimal thickening of the arteries, a lot of interstitial fibrosis. She had sclerotic glomeruli, obliterated interlobular arteries and arterioles. She had a little bit of mesangial hypercellularity, and this is her immunofluorescence. All she had was IgA, one immunoglobulin. She did not have the classic full house. And the diagnosis here was that she had chronic vascular injury, likely from her antiphospholipid antibody. So she's got TMA. And if she had lupus nephritis at all, it was class 2. There's no active inflammation. So why do a kidney? Thrombotic microangiopathy, clotting in the kidney, sorry. And that's, please, this makes me feel like I'm back at Ohio State. I never get through a lecture so. So please, if you have a question, I'm happy to answer. So not all kidney disease in a lupus patient is lupus nephritis. Interestingly, 5% of lupus patients may have other glomerular diseases. And there's an entity called a lupus podocytopathy that may coexist with lupus nephritis in about 1 to 1.5% of the cases. So you remember, the podocytes are covering the urine side of the glomerular basement membrane, and we think that they're very important in regulating what goes through the GBM. So there are patients with lupus that don't have a lot of immune complex disease, but they'll have a lot of proteinuria. And often these patients will have a histology that's either reminiscent of minimal change disease or focal segmental glomerulosclerosis. And we call that lupus podocytopathy. It's treated differently than the aggressive forms of lupus with proliferation, and so making that diagnosis is relevant. The antiphospholipid antibody nephropathy or thrombotic microangiopathy, with or without lupus nephritis, occurs in about 25% of the patients. That's a really important diagnosis to make because you don't treat those patients only with immunosuppression. If you have clotting going on in the kidney, anticoagulation needs to be added if they need immunosuppression. And sometimes they don't need immunosuppression, they just need anticoagulation. Interstitial nephritis, admittedly, is fairly rare in the absence of glomerulonephritis, but it does occur in patients with lupus. And then finally, not all kidney disease and lupus nephritis needs to be treated aggressively with immunosuppression. Class 2 lupus nephritis with a little bit of proteinuria often responds nicely to the other therapies you might be giving for the extrarenal lupus. And then chronic changes with little active inflammation don't really bear aggressive immunosuppressive therapy. So I'm going to come back to the repeat biopsy issue towards the end and try and convince you of a new algorithm that we're trying to implement for diagnostic biopsies. Okay, question I often get is there a proteinuria threshold for the kidney biopsy? When I was a fellow, it was 2 grams. When I was a young attending, it was 1 gram. So the target moves, just like your blood pressure targets and everything else move in medicine. At the Atlanta ASN a couple years ago, there were some very interesting findings. This was from a group from Argentina. They looked at 38 patients with lupus, normal kidney function, only glomerular hematuria, proteinuria less than 500 milligrams a day. They all had biopsies. These were all their very first biopsies. And you can see here that despite this low level of proteinuria, a large percentage, in fact, most of these patients had proliferative lupus nephritis, class 3 or 4. And I'm going to go over the classes in just a minute. This is another more recent study that was published in the journal Medicine, and they looked at patients who had proteinuria less than 500 milligrams a day and even less than 250 milligrams a day. And you can see here that a fair percent of those patients with less than 500 and even 7% of patients with less than 250 milligrams of proteinuria a day actually had proliferative lupus nephritis. So we biopsy if the proteinuria is 500 milligrams a day or more. And if you were to say, but your data here show that maybe you should do it less, I'm happy to be convinced. It takes us very little to do a kidney biopsy based on the proteinuria. Okay, to continue with the case, the biopsy was consistent with class 4 plus 5, lupus nephritis, high activity. High activity means a lot of inflammation, low chronicity. Chronicity in the parlance of the nepropathologist means scar that for the time being is irreversible, and 1 small cellular crescent was seen, and I'll show you pictures of this in a minute. So this is the pathology very briefly, one slide. I won't do it justice. This is class 2 lupus nephritis. So this is defined by some mesangial proliferation. There's some electron-dense deposits in the mesangial region. These electron-dense deposits are immune complexes. And this is the clinical pathologic correlations. You can see some proteinuria and hematuria, renal insufficiency, and nephrotic syndrome are not expected in class 2. This is only, as I said, mesangial proliferation, and these patients do relatively well. Now, unfortunately, we can change classes pretty readily. Class 3 and class 4 are the severe proliferative forms of lupus nephritis. Here, in this light glomerulus, you cannot see any open capillary loops. These patients all have endocapillary proliferation. Now, the endothelial cells don't proliferate very much, so endocapillary proliferation is often meaning they're clogged up with inflammatory cells, and these patients tend to have very profound immune complex deposition. This is a huge immune complex in the subendothelial space. These immune complexes are in direct contact with the circulation. They can activate leukocytes. They can activate the complement system, and so what you get, almost all these patients have proteinuria and hematuria. A lot of these patients have renal insufficiency, and they can also have nephrotic range proteinuria. Endocapillary proliferation, white cell infiltration, crescents, and necrosis by light microscopy is common. And then I showed you the subendothelial immune complexes. Class 3 has less than 50% glomerular involvement, and class 4 lesions have more than 50%. There's a huge debate about this classification. My suspicion is that the nephropathologists are going to revise this soon, and I think it would be a good thing. Okay, class 5 lupus nephritis, and you can't, it's hard to appreciate, but these have thickened glomerular basement membranes, and if you look at the electron micrograph, these are all in the subepithelial space. This is akin to, but not equivalent to, primary membranous nephropathy. It sort of looks the same, except it has more immune complex deposition in the mesangium, and it isn't just IgG that's depositing. These patients have proteinuria, often nephrotic. Hematuria is possible, usually no renal insufficiency. So you can also have class 4 plus 5 like our patient. This is really a great EM. This is subendothelial deposits, and these are subepithelial deposits right under the podocytes. So when a patient gets better, we want them to go from class 5 or class 3 and 4 to class 2, which they might do, or we want these lesions to heal and then they'll have a few scars, but there's no activity. If the patients progress, they go on to class 6 lupus nephritis, and this is a kidney that is on its way to be dead, and the patient will need renal replacement therapy, dilated tubules, interstitial fibrosis, and glomerular sclerosis. Okay, so the patient was told she has lupus nephritis. What should we do? I want to talk about the goals of lupus nephritis therapy because I think we're losing our way. And this is driven by clinical trials and my friends in pharma. The goal of lupus nephritis is to preserve long-term kidney function. We want to avoid the need for dialysis and transplantation. I think you all get that. We also want to minimize chronic kidney disease. Why? Because chronic kidney disease is an independent risk factor of cardiovascular mortality and morbidity. So this is something that I think a lot of people don't appreciate. This was a study, it was published, I think, in the New England Journal, looked at over 1 million ambulatory patients. This is the hazard ratio for cardiovascular events and eGFR. And you can see here, with small changes, so eGFR greater than 60 is taken as normal. Of course, you and I would be unhappy if our eGFR was 60, but just that has a hazard ratio of 1. If you're a little bit below that, you can see that the hazard ratio increases even with that small decline in renal function for cardiovascular events. And these hazard ratios were adjusted for all of these variables which you would expect them to be adjusted for. When you have more profound renal insufficiency, chronic kidney disease, you can see that the hazard ratio doubles or even goes up 3-fold. So this is a big deal. And why is it a big deal? Because patients with lupus, in and of themselves, even though they're young women, are predisposed to cardiovascular morbidity and mortality. And so, to me, this provides an additive bad prognostic finding. And just to show you that this is another study, and this is myocardial infarction, peripheral vascular disease, and strokes and cerebral vascular accidents. Kidney disease stage 1 and 2, and this is the NKF definition of kidney disease stage 1 and 2. And you can see this is the purple bars. They're increased risk for these cardiovascular events. Kidney disease stage 1 or 2 means a structural or functional kidney abnormalities lasting for 3 months. So, what does that mean? That means if you have a GN like lupus and it ends in a scar, you have a structural abnormality of your renal, of your kidney, and even though your eGFR is doing pretty well, right, you're at increased risk of cardiovascular disease. And then stage 2 CKD has a mild decline in eGFR. So you can see it doesn't take very much to have a damaged kidney be a risk factor for cardiovascular morbidity. Okay, I think we may be losing sight of these goals in favor of short-term endpoints of complete and partial renal response. And this is sort of how the therapy is designed now, and we'll talk about what we do for therapy. We start out with a diagnosis of lupus nephritis. We start initial therapy, and I'm going to go over that in a minute. And then we wait 3 to 6 months, and we hope that they're stable, better, or they have a partial response or a complete response. Then the patients are started on maintenance therapy, and at some point we hope they have a complete renal response. And then that goes on for at least a year, generally longer, and maybe we'll consider tapering off the immunosuppression. If you have a partial response, you can continue indefinitely. There is no particularly good guidelines on when to taper maintenance therapy. And then if you're worse at any time, you choose an alternative initial therapy. Okay, why is it driven this way? Well, when we do studies of drugs, you can't have pharma doing trials for 5, 10, or 15 years that are required to look at hard endpoints because it would be not financially feasible nor logistically feasible. So what we're trying to develop are surrogate endpoints that are at a time interval that can be managed in a clinical trial that reflect long-term outcome. And unfortunately, we haven't succeeded. These are the current definitions of complete renal response. As you can see, this is from the American College of Rheumatology. This is from a LUNAR trial, and the ALMS trial, and the ACCESS trial. And the trials aren't important for you right now. All I can tell you is these are recent clinical trials that were completed in the last 5 to 10 years. And you can see the urine protein creatinine ratio on a 24-hour urine sample was different in the trials, with the American College of Rheumatology being the most rigorous. The creatinine, so when you start out with your creatinine, how much can it deteriorate? Well, here it can deteriorate 25%, 15%, 25% are normal. Urinalysis was required in some, but not all. Glucocorticoid taper was required in some, but not all. And nobody requires this response to be sustained over 2 visits, which of course is really important because if you have a response, you want that response to be sustained long-term to improve the prognosis of the patient. What we really need to know is which, if any, of these predicts a good renal survival. So one of the things that we did with the European group was we re-examined the Euro-Lupus Nephritis trial and the MAINTAIN trial. These were 2 trials that looked at using low-dose cyclophosphamide instead of the high-dose NIH protocol cyclophosphamide that we tend to use. And these patients had 7 years of follow-up. We looked at proteinuria, serum creatinine, and hematuria as predictors of good long-term kidney function. And good long-term kidney function at 7 or more years, and we can debate this, was defined as a serum creatinine of 1 or less. Now, we can debate this, but I think we'd all be happy if our patients with lupus nephritis had a creatinine of 1 for the rest of their lives. So let's just accept that for now. And we looked at the diagnostic performance using receiver operating characteristic curves to maximize the sum of sensitivity and specificity. This is a lot of sort of statistical jargon, but that's what they do. And the optimal cutoff was then determined to maximize sensitivity and specificity. That's how you make a good diagnostic test. Okay, so these are the data summarized, and this was in 2 articles that came out, one for the first urolupus trial and one for the maintenance urolupus trial. I've highlighted proteinuria. Proteinuria less than 800 milligrams a day in the ELANT trial. Proteinuria less than 700 milligrams a day, so very good correlation in these 2 studies, gave you the highest sum of sensitivity and specificity, okay? That meant that if you had 800 milligrams or less of proteinuria, you had a very good chance of having a serum creatinine less than 1 in long-term follow-up. And for these, the positive predictive value was around 90%. Okay, so that was pretty good. Now, a couple of things. If you add serum creatinine at 1 year, less than 1, so a really good serum creatinine at the end of a year, you don't really improve the sum of sensitivity and specificity. If you add urine red blood cells, which has been part of every clinical trial until recently, you actually make the sum of sensitivity and specificity worse. Finally, the negative predictive value was quite low. So how do I summarize this? Okay. First of all, these data need to be reproduced in other ethnic and racial groups. These were mainly Caucasian populations from Northern Europe. Other races and ethnicities may need a different level of proteinuria. As you know, lupus nephritis is particularly aggressive in African Americans and in Hispanics. And there were very few in this trial, in these 2 studies. The results probably don't apply to treatments that decrease proteinuria by non-immune mechanisms like the calcineurin inhibitors, okay? And this is a big deal because the calcineurin inhibitor is being found to actually be useful for lupus nephritis, potentially. They will confound the interpretation of proteinuria. What do I think needs to be in place? A biopsy. These may not apply to pure class 5 lupus nephritis, which is mainly a proteinuric disease. Most of these patients had proliferative lupus nephritis. And finally, while achieving the target of 800 to 700 to 800 milligrams actually predicts a good outcome, so a high positive predictive value, it turned out that in these 2 studies of Caucasians with mild proliferative lupus nephritis to moderate proliferative disease, a lot of those people who didn't hit that 1-year target actually also did well in the long term. They had a low negative predictive value. So this test is not a perfect test, but it shows you some of the thinking that's going on currently. The last thing that I don't have on this slide is, because of this test and talking with the FDA, we have successfully, I believe, negotiated that we don't look at red blood cells as an outcome in lupus trials going forward. And as you can imagine, if you and your nephrologists are doing the studies, that's great because you know what you're looking at. If you can imagine all over the world doing these multinational clinical trials, the quality of looking at the urine is marginal at best, then you can understand why red blood cells don't correlate very well. I'm not saying that they're not useful, and certainly we look at urine and we look at urine red blood cells, but we do that within our own division. Okay, how would we treat this patient? I want to make a big plug for antimalarials. This was debated at the KDIGO guidelines, which KDIGO is a kidney organization where we looked at lupus guidelines along with other GN guidelines. And the nephrologist didn't want to include it. The rheumatologists always use hydroxychloroquine or Plaquenil. So these are 2 inception cohorts. And this is the odds ratio for developing lupus nephritis if you have an antimalarial on board. And you can see in both trials, the antimalarial is protective. This is the odds ratio for developing ESRD if you have lupus nephritis and you're on an antimalarial. as opposed to not being on an antimalarial, again, protection. This is the odds ratio for a complete response to standard of care therapy if you have lupus nephritis and you have an antimalarial on board. And of course, this is a higher odds ratio suggesting that, again, the antimalarial helps you with your management of lupus nephritis. All of our patients, unless there's a contraindication, are put on hydroxychloroquine when they come in. Okay, I made a mashup of the American College of Rheumatology guidelines, the KDIGO guidelines. Okay, this is kidney disease improving global outcomes, in case anyone cares. And this is EULAR, the European organization, something against rheumatologic disease. Right, Sam? Something. I was close. Okay, so it turns out that in 2012, all three societies made guidelines. And the guidelines were pretty much the same amongst all three societies. And for full disclosure, many of us who participated in one of these participated in others of these, including me. So these are the guidelines as they stand. You have proliferative lupus nephritis. You have to decide if it's severe. If it's severe, you can give IV methylprednisolone. If it's less severe, you can start with oral prednisone. And then you have the following choices of therapies. You can have low-dose cyclophosphamide, you can have oral cyclophosphamide, or you can have high-dose intravenous cyclophosphamide. So it's cyclophosphamide, 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 or MMF. Okay? This is where we are right now. Now, if you talk to me in a year or two, we might add a calcineurin inhibitor there, but not as primary therapy. And then you get to the maintenance phase, and you can use either MMF or azathioprine or a calcineurin inhibitor like cyclosporin or tacrolimus. Okay? So how do you choose? And that's what I want to talk about. The patient was told she has lupus nephritis. She was started on an antimalarial. Blood pressure was carefully watched. We kept it under control. Dietary restrictions went into place, salt restriction, etc. For her, we recommended high-dose prednisone and mycophenolate. Why? Because she's during childbearing years, and we wanted to preserve ovarian function. Okay? And you take a risk when you're using oral cyclophosphamide because the dose for a 70-kilo person over the amount of time that you use it is about 10 to 12 grams of cyclophosphamide. With the NIH protocol, it's 6 to 8 grams. It's fairly similar. With the low-dose cyclophosphamide protocol, which is the European protocol that I talked about earlier, that's a total of 3 grams, and that's associated with much less ovarian failure. So that is a possibility in these patients, and truthfully, that's what we tend to use in our practice, but I want to open this up for a little discussion. So because of the ALMS trial showing not superiority, okay, I have to be clear. The ALMS trial was done a head-to-head comparison of oral mycophenolate with intravenous high-dose cyclophosphamide, and the idea was that the oral mycophenolate was going to be superior to the cyclophosphamide, and it was not. It was not inferior, but it couldn't get approval from the FDA because it was a superiority trial. Now, people adopted the mycophenolate because they said the side effect profile was less than the cyclophosphamide. And I just want to point out, if you read the paper, the side effect profile was not less, it was different. So plenty of patients with the MMF had a large number of side effects, the most frequent being gastrointestinal side effects, as those of you who use the drug know. Now, MMF presumably does not have effects on fertility, nor does it have effects on downstream malignancies. So yes, the side effect profile is different, but it is still have a lot of side effects. There were a lot of deaths in this ALMS trial. They were mostly in Asia. In Asia, everybody was being dosed to a target of 3 grams a day of the mycophenolate, which is a very large dose for a small Asian population. And so that sort of goal has been modified now. But anyway, this is what we recommended for this patient. So What I wanted to try and talk about was something a little bit more novel. The patient said no to the steroids. She said that when she was on 20 milligrams a day for extrarenal lupus, she ate all the time, she couldn't sleep, and she wasn't able to concentrate at school, all of which you probably see with your patients. So, should we treat her with MMF alone? Should we treat her with cyclophosphamide alone? Or should we discuss a steroid-sparing protocol? Anybody want A or B? Oh, somebody, 2 rheumatologists do. Okay. So I didn't know if you're a rheumatologist. I know the other. Okay. So let's talk about C, because C's the winner. I think all of us who treat patients that require anti-inflammation think steroids are great drugs that are fraught with a lot of difficulty. And so a lot of us are trying to mitigate the dosing of steroids. This is a protocol that was started at the Hammersmith in London, and it's called the Rituximab protocol. It is steroid avoidant. Okay. So this is a single center study. The patients had 3, 4, or 5 lupus nephritis, and then they weren't on steroids. Rapidly progressive renal loss was excluded, as was CNS lupus. The patients got 2 doses of rituximab, 1 gram each, separated by 2 weeks, 2 doses of IV methylprednisolone, 500 milligrams with the rituximab, no oral steroids. Maintenance therapy was mycophenolate. That was started after the rituximab was done. They started with 500 milligrams twice a day, and it was titrated up to about 2 grams daily. Okay, no oral steroids. So what were the results? 50 patients, only 4 haven't reached the 5-year follow-up. This was presented at the ASN 2 years ago. The median follow-up was 77 months. This is the breakdown of the patients. They were mainly white and Asian. And this is the one little sort of unusual part of this trial. 44% of these patients were class 5 lupus nephritis. I would venture to guess you guys don't see 44% of your population being class 5, pure class 5. I would say most of your population here, like our population, is proliferative. So I do think this was a little bit of an unusual statistic. Nonetheless, if you look at the remission rate, this is complete and partial remission. The total remission rate was 88%, and it was pretty similar for all the classes, although the numbers are kind of small, the best in class 5. Median time to remission was about 9 months. This is very similar historically to what we see using oral cyclophosphamide, which is what we have tended to use at our institution. There were 19 renal flares during the follow-up period. The median time to flare after remission was about 2 years. So this is, again, historically compatible with steroid-containing regimens. 80% of these flares were managed without the addition of oral steroids, which is really remarkable because that's sort of the go-to when a patient has a flare. And about 70% of the patients were simply retreated with rituximab and had a good response. Extrarenal flares were very rare, and those were also not treated with oral steroids. So this actually engendered a phase 3 trial called the Rituximab trial, which is multinational. We're doing it in the United States, and we're doing it in Europe, and it's sort of on hold right now because of some problems with the European Rheumatology Association. But that's a possibility. I'm just throwing out a possibility that, down the road, you may see steroid-free or steroid-reduced protocols with lupus nephritis, and I think that's important to keep in mind. All right, let's finish up. The patient eventually agreed to mycophenolate and steroids at a lower dose than I usually use, but a rapid taper. So after 6 months, her serum creatinine was 0.9, so it's moving in the right direction. Her proteinuria had gone from 5 to 1 gram a day, complement levels normalized. After 12 months, her serum creatinine was moving in the right direction. Her proteinuria was gone. She felt well, and she had no extrarenal symptoms. 3 years later, she's feeling well. She had gotten married. She was considering children. All of these things are normal. Okay. You recommend the following. Get rid of the MMF, because she's been on MMF this whole time. Okay, she's been on maintenance therapy this whole time. Change to azathioprine, because you can have a baby with azathioprine. change to calcineurin inhibitor because you can have a baby with calcineurin inhibitors. We know this from the transplant literature. Tell the patient never to have a baby, and don't laugh. This is, some of the patients come to me that way and they haven't had children. This is a big deal for young people. Or repeat a kidney biopsy to inform your treatment decision. Anybody for A? You can say yes. Okay, A. How about B or C? D? Hopefully no one's for D. Who is? No, I'm not for D. I'm for E because we biopsy everybody. In fact, we'll line you up afterwards here, and I need normal tissue. Okay, so here's the deal with maintenance therapy. After a complete renal response, it is suggested that therapy be continued for 1 year before tapering. I suggested that with absolutely no evidence in the KDIGO guidelines. And it says no evidence, okay? I mean, I'm not saying, if you look at maintenance therapy in a whole bunch of randomized controlled trials, these are the references, the median duration of maintenance therapy is 3.5 years, or mean is 3.5 years, median's 2 years, and sometimes it's forever. Okay, so what could we learn from a repeat biopsy, and how could that help us determine the length of maintenance therapy? So this is a study we did. Serial biopsies were done in a cohort of 25 Hispanic patients, female, young. Biopsy 1 at the time of diagnosis. Biopsy 2 after induction therapy. Biopsy 3 during maintenance therapy after, get this, 42 months of total treatment, 30 months of clinical inactivity, as good as it gets. These were treated in the same way that you and I would treat patients with NIH cyclophosphamide and MMF, and then maintained with MMF or azathioprine. Okay, this is what happened to the serum creatinine from biopsy 1 to biopsy 3. It improved. The proteinuria went away. C3 improved. C4 improved. These patients did as well as you could expect any patients with proliferative lupus nephritis to do. So, what was the histologic activity at the third biopsy? Remember, they were clinically quiescent for 30 months, renal and extrarenal disease together, clinically quiescent. So, the activity index is an index that the pathologists use to tell you how much activity is in the biopsy, which generally means inflammation. Proliferation of cells, infiltration of leukocytes, crescents, necrosis, bad stuff. Chronicity is the opposite. So, a lot of the people had no activity left, but after all that time, with no clinical evidence of disease, a lot of these people actually had, these are the complete responders, a lot of these people still had activity left. And the activity wasn't just simply some subendothelial immune complex deposits, which is a measure of activity. It's one of the components of the activity index. These patients had crescents, these patients had interstitial inflammation, these patients had endocapillary proliferation. Interestingly, look at this column. These are patients who were partial responders. A partial response means their serum creatinine was fine, but they had continuing proteinuria. This is a lot of our patients. Our patients get better, the proteinuria may not totally go away, and it may not go away not because of ongoing disease necessarily. As you can see, a lot of these partial responders had no activity, but they have remaining proteinuria because you have damage to the kidney that heals with scar and you have leakage of protein. And you would never know that if you didn't have the biopsy, okay? So these patients, you might say, well, they have considerable activity left. It might not be a good idea to taper their immunosuppression. These patients, you'd say, well, they're doing pretty well. Maybe we can actually get rid of their immunosuppression. I'm just throwing it out there. Is there some guidelines as to what a repeat biopsy activity or chronicity index means? This is a nice study out of the Middle East, and what I want to point out here is they're looking here at doubling of serum creatinine, which for nephrologists means a harbinger of end-stage renal disease, a bad prognosis. If the patient at the second biopsy after treatment has an activity index of 0, so the inflammation is gone, over 10 years, they have virtually no chance of developing end-stage renal disease. They do pretty well if the activity index is 1 or 2, but if the activity index is greater than 2, they have a big chance of developing end-stage renal disease, or doubling of serum creatinine. Now look, oh, I want to go to the previous slide. Look at these people. A lot of these people, after all these years of quiescence, had activity indices that were greater than 2. Okay, similar for the chronicity index. I'm going to skip that so we have time for some questions. So this is my last slide. So I'm throwing this out there mainly to be controversial and see what the nephrologists and rheumatologists in the audience think. So I'm suggesting the following. You have lupus nephritis, you perform a diagnostic biopsy, you have induction therapy followed by maintenance therapy, and then you have outcomes. And let's concentrate on this side. There's other data for this that I don't have time to show. So let's say you have a partial clinical renal response, but the patients are doing real well. Well, I just showed you that a lot of those patients may actually have no active disease. So a repeat biopsy may show resolution and that you can indeed safely taper therapy. Or they can have a complete renal response. The complete renal response is sustained. You've kept them on maintenance for a long time. You're going to consider stopping therapy. You could rebiopsy to verify that they have histologic remission, and then if there's no activity or the activity index is less than 2, then you can consider tapering therapy. Now for flares, so you have a complete response and then the patient flares, it's a little more complex. And I don't really want to go into a lot of this. If the original biopsy was... What you learn in the textbooks is that lupus can change histologies very rapidly. And it does change histologies, but if you look at most of the biopsies that were done for flare, the changes in histologies are mostly going from a non-proliferative GN, like a class 2 or 5, to having a proliferative component. So I suggest that if the reference biopsy was class 2 or 5, a repeat biopsy at flare may help you show that there's proliferative disease. If the patient had proliferative disease to start with, not very many of those simply, when they flare, go back to just class 5. Okay, so that biopsy will be less useful. And that's the end, and I'll have time for questions, I hope. Thank you. Yes?
Thank you for that comprehensive talk. Just a quick question.
Yeah.
What is the variability or the sampling bias that you have in a biopsy? I mean, you know, you're making decisions basis went from 5 to 3, but
right.
But I mean, the kidneys are huge.
It's huge.
And your biopsy is very small.
It's huge. No, so that's exactly right. So you know, and I'm glad you asked that, because usually if nobody asks me questions, I ask it myself, because I'm, you know, trying to be transparent. The sampling bias in a kidney biopsy can be quite high. And we can talk to nephropath, but what we want to see is at least a minimum of 10 glomeruli to make sure that we know what we're seeing is correct. And I will tell you, and I think it's very hard, there is no really good definition of how much interstitium we need to make sure the tubulointerstitial space. So we can kind of get that from the transplant experience. It was done years ago. The investigators at Rush actually developed an algorithm of how many glomeruli you need and what % error there was. So with 10 glomeruli, I think the error could be as much as 20%. With 25 glomeruli, it was much less. When I asked my nephropathologist, how many glomeruli do you need to feel confident in your diagnosis, his answer is all of them. So now, but I want to defend myself to some extent. I agree that this may not be the best way to do this, and there may be sampling error, no question. What we're trying to do, and what Sam alluded to, was we're trying to correlate pathology with urine biomarkers, because the urine biomarker sort of integrates everything in the kidney. And what we're trying to do is find biomarkers of inflammation and biomarkers of fibrosis, okay? We've published some of that stuff. We have The positive predictive value, the negative predictive value of our biomarkers was quite good. We could rule things out really well. The positive predictive value was like a coin toss, so we're not quite there yet. One more exciting thing on this question. I don't want to, if other people have questions. We're starting a trial soon, I hope, where we're doing a biopsy paired with MRI. And it's going to be MRI with gadolinium, and it's going to have a whole bunch of different parameters. And what we're hoping to do is this is with Peter Lipsky and the Lucen group. What we're hoping to do is see if we can use that to correlate with fibrosis and with inflammation, just two gross sort of things, because those are what we're sort of interested in. We don't want to see increasing fibrosis, and we do want to see decreasing inflammation. So I think it's a really important question, and I totally agree with you. It's what we have as the gold standard. So, yes.
I sometimes feel like we're taking people with different diseases into the category of lupus. In terms of maybe these people that have different responses or different presentations really actually have different diseases.
Yes.
And we call it lupus, but it's actually different diseases.
So I'm glad you brought that up. If anyone wants to come tomorrow to the rheumatology rounds, right, grand rounds, I'm going to talk about that. And what we're doing now is really, I think, very exciting. We're looking, so I hope you'll agree with me, Brad, that we're in the dark ages with nephropathology. We look at a slide, class 4, every class 4 looks bad, right? But they're different. And so we're taking the kidneys apart with laser dissection microscopy, and we're actually looking at the molecular signatures in the glomeruli and the tubulointerstitium. And we're trying to understand what's going on in the kidney, because I think some patients have X pathogenesis, and it leads to the same end histology, and some patients have Y. And if you can pick out X or Y ahead of time, then you can really target your therapy to the patient. So precision medicine, personal, whatever you want to call it, okay? It gets different catchwords. I guess Obama made a speech, right? And it went from personalized medicine to precision medicine. So now that's the cool word of the day, but that's the idea. And I'll show some of those data tomorrow. We haven't quite got what I just said, but one of the interesting things we're finding is if you do a biopsy at the beginning and you have the molecular profile, and then you repeat the biopsy after induction. And these patients had a complete response to induction, so a good response. 6 months, they get all better clinically. And these patients didn't have a complete response. These patients look different than these patients. And there's actually targetable pathways in the non-responders. So my suggestion is, and I'm really preempting myself for tomorrow, but I'll show the data tomorrow, is that you could use that and say, this person's interferon signal is still up. Let's use an anti-interferon drug. This person's complement signal is up. And then, of course, the next phase of that is to say, okay, do you have to do the repeat biopsy, which is invasive, or can you actually get something in the urine that you could use? And I'll show one slide on that. We're starting to make some progress in that. So very important question. I think that's exactly right. I think what we've done is, and I think one of the failures of clinical trials is that to increase recruitment in a heterogeneous disease, we take everybody. And when we do that, we're shooting ourselves in the foot. I think we can do smaller clinical trials with well-characterized patients and get an answer. And you can't convince a drug company. Are the drug company folks here maybe sponsoring it? If there are, I hope I'm not offending you, because I work with the drug companies. But the point is that I think we have to be smarter about how we design the trials. That's exactly right.
Brad, that was a wonderful talk. Thank you so much.
Okay, thank you.